So good evening, everyone. Thank you for the patience which you have been showing. We all are now live and we'll be going on with the presentation immediately. We are lucky today that we have Professor Alison Campbell setting aside us for this session. We have been doing these international sessions for every month now for education or globally for all the embryologists. And with the help of Ritesh sir, we could get it every month on month with one or another international speaker. And we, for the same, we have today Professor Alison Campbell with us.
And apologies, this time the session was supposed to be held on third Friday, but instead of third Friday, it is being done on the fourth Friday. But from in future, it will be happening every third Friday, 5:30 p.m. mostly, and you'll be updated once we finalize the dates and the time. So without wasting any time, I think it's the time to introduce Professor Alison, and we'll start with today's session.
Great. So as such, I think she doesn't require any introduction. She's a very popular face and a very popular name globally. She is currently working as a Chief Scientific Officer at Care Fertility Group, which is the largest group, I believe, in UK. And she's consultant embryologist and fellow of Royal College of Pathologists. She is also right now Vice President of Alpha Scientists in Reproductive Medicine, one such group who have been doing in a lot and pouring in a lot of the brains for the benefit of the Embryology Society overall. And we have been getting a lot of guidelines and helps from them for the same. She's a part of editorial board for Human Reproduction and RBMO, that is Reproductive Biomedicine Online. And she has established a dedicated practical training center for embryologists, which has become the home to UK's first university industry joint master's degree in clinical embryology. She has over 116 publications with more than 2,790 citations. So this is just some benchmarks, which I would say we have mentioned it over here. Otherwise, the list goes pretty long. So we are very happy to have you, Professor Alison, today for such an important session and the topic, and that is the effect of the embryo grading on the cryopreservation and survival. Both are such subjective things and a practical work which troubles every embryologist. And with the combination of that, we believe the session would be pretty insightful for everybody attending today. So thank you very much for your time, and maybe we can start on the session.
Thank you. Well, it's my pleasure to be here at the Indira Fertility Academy. And it's the second time here, actually, and it's in the beautiful city of Udaipur, the city of lakes, so it's a privilege to be here. And I'm even drinking some masala chai tea, so I'm really feeling at home. So, we have the slides, yes. So I'm going to talk about the impact of embryo grade on cryosurvival and clinical outcomes. So, as Naval has said, this is a huge topic. It's very important. And I'll go over some of the literature, some insights, and hopefully we'll have some learning points and some discussion at the end. Okay. So let's start with vitrification before we go on to embryo grading, and then we'll come back to vitrification again because they are intertwined. So we know that vitrification has so many advantages, and most importantly, it's helping us to increase the cumulative live birth rate per cycle. So we use it with PGT, we use it to reduce the risk of ovarian hyperstimulation syndrome for fertility preservation. So for many different reasons, so an effective blastocyst cryopreservation program is absolutely essential for every IVF clinic. And just a reminder of the differences, we used to perform a slow freezing using a computer control system. And this took a long time to get down to the critical temperatures where we would cryopreserve the samples. And now vitrification has changed everything. It's very fast. So the cooling rate and the warming rate, very rapid, which helps us reduce the risk of cryo injury and osmotic stress. And we're probably all familiar with blastocyst vitrification program. We need a very fast cooling rate and a very fast warming rate. It is reliant on viscosity, so the cryoprotectants, ethylene glycol and DMSO usually, and we want a low volume as well. So these elements working together will give us the best possible vitrification protocol, which we can talk about in a little bit more detail. So first of all, the cooling procedure. We know that the cells will lose water and they will shrink in the equilibration solutions. And then they're incorporating the cryoprotectants and they start to reform their shape. And we're using these cryoprotectants like DMSO and ethylene glycol, and we use non-permeating cryoprotectants like the trehalose or sucrose. And then in the vitrification solutions, following equilibration, the cells will lose water and they'll shrink again. And we load them onto the cryotop or the straw, the device that we're using. And then we'll plunge them into liquid nitrogen and get the very fastest possible cooling rate that we can. And then when we want to reverse the process for warming, we're using only the non-permeant cryoprotectant. So the trehalose in this example, which I'm talking about, kitazato, then that's through a series of decreasing concentrations of this. And we're then gradually controlling the movement of water to enable the rehydration. So we can mention a little bit later about the possibility of an ultra-rapid warming process, which has started to really gather momentum around the world, whereby we plunge the straw, the device, which is vitrified, into the thawing solution for 1 minute, and then we take the sample, the embryo, or the oocyte, in some cases, into the culture medium. And it's widely believed that the warming rate is the most critical step. Some early studies on mice showing that the higher warming rate gives us a lower risk of recrystallization, which can cause damage because of intracellular ice. And this will give us the highest survival rates. And now we know that there are so many factors that affect cryosurvival. But we just think about a few of them, like consistency in practice, how we load the sample, the skills of the embryologists, the environment that we're working in, those cryoprotectants, temperatures, the timings, the training. There's so many choices that we have to make, and the handling and storage of the samples once they're cryopreserved. And the big one, I suppose, is the initial quality of the blastocyst. So we'll look at that in a little more detail. So if we had to summarize how we should set up for success with vitrification and warming, I'd say these are really the elements that we need to focus our attention on. This is as well as the blastocyst quality and selection. So it's the device and the media selection. So the protocol is really important. And it's generally advised, well, it's always advised from me to follow your manufacturer's instructions. That's the SOP that's been proven, it's been validated. So that's the way we should be working to get the best possible outcomes. Staff training, of course, is very important. And I know that Indira take this very seriously, and hopefully all networks and all standalone clinics will also do this, because everything hinges on the talent and the competence of the staff performing the vitrification and warming. And how do we know they're performing properly? Well, we have KPIs such as blastocyst survival, and we can look at this as a clinic, as a laboratory, or as individual practitioners. And when we find that the practitioner is perhaps not performing as well as the rest of the colleagues, that's fine. At least it's been identified and we can work together to try and make that improvement. So troubleshooting the protocol is also very important. So we need to understand why we're doing what we're doing and do it the best that we possibly can. So let's move on to blastocyst morphology and how it might impact our vitrification practice. So we can think about post-warming survival and clinical outcomes according to the original blastocyst morphology. Now we know that blastocyst grading is subjective, and this is a challenge worldwide. We know this. And we've largely been basing our blastocyst grading, I think, on the Istanbul 2011 consensus. So there was a survey that was conducted by Eshrei and Alpha quite recently, asking clinics across the world how they grade their blastocysts, do they follow a particular scheme, and importantly, do they use the Istanbul consensus for their assessments? And 539 centres completed this survey. 63% were in Europe, so that was the majority, and 23% of the centres responding were from Asia. And we can see that the majority, so around over 85%, reported that they were using the Istanbul consensus for embryo assessment, either entirely or at least partly. And the majority, over 55%, were using the Gardner scoring scheme specifically for blastocysts. So based on that survey and a group of experts coming together, there is a new Istanbul consensus. So it's not currently published, but it has been out for feedback worldwide. So there have been a lot of communications around the detail of this. It's a very big document. It needs a couple of lectures all on its own. But importantly, I think that one of the main points is that there is no recommended cutoff for utilisation of blastocysts. So it would make our lives much easier if we were told by the literature and the experts that these blastocysts should be vitrified and these should not. But life is not that easy. So generally speaking, the ranking is based firstly on the expansion, being larger expanded blastocysts are better and for clinical outcomes, with inner cell mass and trophectome traits of A and B. So probably what we would expect, higher morphological grading and more expansion, we expect will get better outcomes. And I thought one of the interesting points that was discussed during the consensus, and it's been seen in the literature, a recommendation that the culture of early blastocysts, so their expansion 1 or 2, according to the Gardner scale, on day 5, should be extended to day 6 before vitrification, because they will survive better, according to several publications. But this is still not straightforward, because day 5 can mean different things to different people. Day 5 at 9 a.m. could be is very different to day 5 at 4 p.m. So we need to take that into consideration when we're assessing our blastocysts and making important decisions based on this assessment. Just to share a little bit of information from Ket Fertility, this is our blastocyst grading scheme. Currently, we're reviewing this based on the Istanbul consensus recommendations, but it's very much based on the Gardner scheme. I put the Gardner letters in red just to show it directly translates. We just found it better to use letters for our multidisciplinary colleagues, FB being 3 or blastocyst, it's just easy to remember, and 1, 2, 3 ABC, it's the same thing, it's very much transferable. But this is exciting, I think. The Istanbul Consensus Update 2025 should be published soon, has introduced a grade D. So this is for non-viable blastocysts, and they should be graded D based on whether they have degenerate features or if they have an absence of a distinct inner cell mass. So some examples only here, just to say, our lives might be easier, I think, if we have this D, because it's a blastocyst, but I don't see an inner cell mass. What were we supposed to do before a C? It's not really utilizable if it has no inner cell mass. And equally, if the trophectome is completely degenerate or just very few cells, degenerate areas, likely to be non-viable, and this would be considered a D. So it just helps us categorize our blastocysts, I think, a bit more easily. Just might take a little bit getting used to. So some of the literature here, we can see that trophectome quality is more important than inner cell mass for live birth prediction. And this was quite a long time ago, a nice publication based on fresh embryo transfers. And the literature generally supports this, that trophectoderm quality is more important. And there's more evidence here. This was double embryo transfers and various blastocyst grades. So they categorized, or split them into 3 groups of double embryo transfers. So group 1, where there were 2 high quality blastocysts. Group 2, where one of the blastocysts was high quality and the other was not so. And group 3, where neither of the 2 blastocysts were high quality. And we can see that there's this linear relationship going down as the groups go 1, 2, 3. So the best rates where we have a double good quality pair of embryos, and the worst where we have 2 poor quality. So you can see very high success rates, 87%, then 69.6, and then 43.8. And I think it's important that we just consider, though, the risk of twin pregnancy, 36% twin rate in this group 1, and down to only 2% twin rate in group 3. So trophectoderm grade, very important, and also day of vitrification. Both of these have been shown to be most correlated with the chance of live birth. This was a nice publication here in 2021 by Coelho et al. And this was the Spanish group. And they did a retrospective analysis of over 12,000 blastocysts. So it's a regression analysis. And the key points from this study were that the odds of live birth increased 3 times where the trophectoderm was graded A compared with C, and doubled the odds of live birth for blastocysts that were vitrified on day 5 compared with day 6. So we'll move on a little bit to talk about the blastocysts a bit further and vitrification. But I think it's very important to remember that most of our vitrified warm blastocysts will survive. So we just need to try and continue to optimize and choose the best ones to get even better outcomes. So let's think about outcome measures and the literature. So we're thinking about frozen embryo transfers. And the first outcome measure, embryo survival rates. Well, we know that most embryos will survive vitrification and warming. And we can see that these are comparable at different stages of development. So we get comparable outcomes with earlier blastocysts through to more expanded stage blastocysts, but clinical outcomes may be different. So just because the embryos survive doesn't necessarily mean it's going to directly relate to the best possible clinical outcomes. And we also know that embryo quality can impact survival rates. So poor quality embryos, poor trophectoderm and inner cell mass tend to survive less than the ones with higher morphological grading. And when we look at live birth rates and the literature, we can see that the expanded blastocysts on day 5 with higher trophectoderm grade achieve the best live births. And frozen embryo transfers, clinical outcomes, in summary, will depend on blastocyst development. So day 5 is better than day 6, is better than day 7. And the morphology of the trophectoderm, re-expansion before the frozen embryo transfer. So after warming, we'd like to see them re-expand, and that gives us more confidence in the chance of success. But also the number of vitrified blastocysts is correlated to positive clinical outcomes. And PGT, we mentioned that this is a very important indication for vitrification. So the rate of re-expansion will depend on several factors, the time between the biopsy and vitrification. And this is not absolutely known. We know there's probably a correlation here and it needs more research, but commonly the recommendation and the practice is 1 to 2 hours. So between the biopsy and the vitrification, generally speaking, clinics choose 1 to 2 hours, and there's no evidence to suggest that that isn't good practice. We think that is probably the best at the moment, but we do need more research to confirm this. and the morphological quality of the blastocyst and the day the blastocyst or the biopsy is performed on the blastocyst. We also know, of course, that we need increased success when we have a prepared synchronous endometrium. So with PGT and any embryo transfer, whether it's euploid or untested, it's best to transfer onto a synchronized endometrium. So we work with our clinical colleagues to optimize the timing of transfer following our warming. And we also know that the number of cells that we biopsy can affect the clinical outcome. We have to make a balance here so that we can get a suitable number of cells to get a reliable result, but we don't take too few or too many. So the recommendation here is 5 to 10 trophectoderm cells for biopsy. So why do we sometimes see blastocysts failing to survive freezing or vitrification and warming? Well, we can get this crystal-induced damage. So we talked about the recrystallization at the ice. We can still get this. It was much more common in slow practices, slow embryo freezing, but also with vitrification, we can get crystal damage. We can also see oxidative stresses, which can be sustained during the freeze-thaw process. I think we need to protect our media and avoid too much light exposure so that we can minimize the risk of oxidative stress during the procedures and induced by the toxicity of our vitrification solutions. And this is why we try and work quickly, we adhere to the protocol, because the embryos are quite vulnerable during the vitrification process. Practically speaking, sometimes if we have air bubbles on the device, then these can cause mechanical damage to the blastocyst. So we need to try and avoid bubbles, and we need to use a pipette that's suitably sized, because if it's too narrow, it can cause mechanical damage. And we need to follow the protocol and not delay into plunging into the TS, but also into the liquid nitrogen on the vitrification step, and then into the TS on the warming step. We need to adhere to the timings. So any delays here can cause damage and affect cryo survival. And I also think I put this picture here because I also think we need to be very careful and mindful that the samples, when they're vitrified, they're in a glass-like state, and we know that glass is fragile. So we need to treat these straws as very fragile. And when we're looking for the straw for warming, or when we're finding a place to put them into storage, we need to be careful not to crush them together, which can also cause damage. So loads of considerations whether to vitrify or not to vitrify. PGT, yeah, we have to vitrify. We want to get the samples over to our genetics testing facility, and so we vitrify to play for time. But sometimes I wonder if we may be more forgiving in terms of the blastocyst selection for vitrification because we're performing PGT. So it's hard to be objective, but we need to try our best. So we've got the morphology we've spoken about in more detail, but the trophectoderm inner cell mass, the degree of expansion, and also the day of culture are many considerations that we need to take. And of course, there are other factors. We have patient wishes. Sometimes patients will really want us to vitrify an embryo that we normally would not because of its morphology. Medical opinion, of course, the clinicians, the medics have an opinion, and they know the patient, so they've had a discussion and they know what they want to happen. So we have to consider this, of course, as well as the number of embryos, previous treatments that patients may have had, perhaps their age, and of course, the cost. So how are we going to get more objective and get consistency? I think quality assurance is really important. And there are many ways to do this. One example is ART Compass. And we've used this in our clinics at Care Fertility. And it's nice, it's simple. We can see an image on our phone or on a tablet of an embryo. And it asks us, would you thaw this would you transfer this? Would you culture on, or would you warm another? So it's really giving us different scenarios so that we can see what we would do, see what our colleagues would do. We don't necessarily know the right or wrong answer, but it's useful to help us try and work in a more consistent way and to gather the data so that we can try and continuously improve. So in terms of take-home messages, I think we'll keep them simple. For successful cryopreservation and, very importantly, for continuous improvement, we do need consistent blastocyst grading and data collection. I think the only way that we can continuously improve is by collecting good quality data and working as consistently as possible. And the following list here are preferred to give us the highest clinical outcomes, bearing in mind there is no recommended quality cutoff for blastocyst utilization. So these are blastocyst expansion and day of culture, trophectoderm morphology, inner cell mass morphology, but to a lesser extent. It's less powerful for predicting clinical outcome than trophectoderm and than expansion grade. And I think it's more difficult to assess it and grade it objectively. Ideally, we need to see post-warm re-expansion, and we must always try and carefully store and handle our cryopreserved materials. Thank you very much.
Thank you, Professor Alison, for such an insightful and thorough presentation. In fact, it was right from the medias which are used to which stage of embryo it should be cryopreserved. Everything you covered, all the aspects. And now it's the time for our audience. So, should you have any doubts or queries, you can just type it in the chat box, or you can type it in the question answers, and we'll take questions one by one. And by the time we start getting the questions, I was just noted that you, in one slide, you mentioned you put a lot of stress on selecting the embryos on the basis of trophectoderm grading. So my question is that, okay, let's say there's a blastocyst whose trophectoderm is graded, but what about the inner cell mass? So we cannot actually ignore the inner cell mass, otherwise it's going to end up giving a blighted pregnancy. So what's your take on that? Like,
yeah, we have to be mindful. We have to assess both the trophectum and the inner cell mass, and we need to be sure there is an inner cell mass. We actually make sure there's only one inner cell mass, because we know sometimes if we've got two, we end up with dizygotic twins. So, yeah, you have to, when you're faced with a predicament and you're not sure, I think it's important to ask an experienced colleague to get a second opinion to rotate the blastocyst, because you can see things on different angles. If it's not straightforward, then let's rotate it with a gentle pipette movement, very gentle, and then let's have a closer look to make a better decision. But trophectum by morphology is more important. Yeah.
And it's quite tricky. Looking at two inner cell mass, identifying two inner cell mass, it's quite a tricky situation.
It's very difficult, and we have one opportunity to do this, and this is a dynamic embryo. And we know from the time-lapse studies, we've all seen the time-lapse videos, and they're remarkable. And they move, and the blastocysts collapse, they re-expand, sometimes they seem to rotate, and then they hatch up. So it's really difficult. And if we don't have time-lapse, like most labs do not, you make one observation, and that is going to dictate what happens to that embryo. So I think it's important that all embryologists, when they're making that observation, they do it the best they can and consistently, and stay focused. And if you're not confident or sure, ask a colleague to check.
Yeah, so basically the kind of take home is that if you are unable to see the blastocyst or ICM at that focus, change the focus up and down. If still not possible, just rotate it with the help of some pipette in the laminar and check it again. but with the caution that do not overexpose the embryo. Right? And with that, if it is also for true inner cell mass, at time one can be very small and another can be a big one, so it goes unidentified. But it is pretty much sure, it is pretty much recommended to check it appropriately so that we don't end up with kind of twins or maybe a monozygotic twins along with another kind of embryo also being implanted, so it becomes diamniotic but also has a monozygotic and becomes all complications. So to reduce the multiple pregnancy rate, please be very careful while checking the grades of the embryos.
One more question. Coming on to the next question. I very often get calls from my embryologists and they often ask me as how to recognize cryo injury. Is it the redness that they see in the blastocyst that is the cryo injury, or if we need to see whether it is expanding or not expanding? So if it is expanding, they think that okay, this is the perfect blast and it's expanding and it can be transferred. So what is the best parameter?
Well, I think re-expansion is a really good indication that the embryo is in reasonable health. So I think that is a very important metric. And we need to also remember that these degenerate patches, these apoptotic areas, it's quite normal to see them in a blastocyst. We don't like to see them, but cell death is a normal thing. So cells are dying and cells are being created all the time. So we can cope, we can handle, we can accept several dark patches and spots. But it's when it's too much, like we're now on this grade D, when almost all of the embryo, well, even though it looks like a blastocyst, it may have expanded, but we've got a lot of degeneration then, or no inner cell mass, then we can score it D. But I think that cryo injury is generally observed as degeneration, high level degeneration, and or failure to re-expand.
I think the first question also is actually related in a way. Reason behind extra cell formation along with trophoectoderm after thawing process and the embryo also not expanded. I mean, we exactly don't get it, but then possibly at the time of expansion, when the actual embryos are expanding, there might be some extracellular cells which are moved out. But in the process of expansion, they just get kind of at the end of a zona and they get pushed and becomes very thin. But when they freeze and thaw, possibly these are the debris which can be seen, which are kind of degenerated, and they are not a part of the blastocyst, but maybe something which was popped out during the formation of the blastocyst before freezing, and they seem to be more degenerated and red. So it is very much essential also to differentiate: is it a part of a blastocyst or it is a debris outside which has got degenerated?
Exactly. I often tell my embryologists to differentiate between the embryos, whether they are really hatching or it's just the oozing of a few cells out of it and they label it as hatching blastocyst.
Yeah, because when you pet them, sometimes those cells that just peep out, they just fall away.
Right.
So it's not connected, it's not connected tissue. Yeah.
The next question is pretty much interesting. Rishika Vishwas has asked, how can an embryo grading be integrated with other technologies such as single cell analysis or genome editing to improve genetic outcome in frozen embryos?
Yeah, well, it's a good question. I think we know from PGTA that if we have a euploid embryo and good morphology, we get the best outcomes. So there's a place to layer these different technologies to try and get the marginal gains and improvements. And time-lapse is another example of this. So we can have magnificent AA embryos with a terrible morphokinetic profile. So if we have that on top, and we could have euploidy as well, we need to balance these different scores, and we need to do a lot of research to understand which we should rank, which we should prioritize. So at least with time lapse and with PGTA, I think both of those are more powerful predictors of outcomes than morphology, than embryo grading. Saying that, if we have a series of euploid embryos of different morphological grades, then we will select the one with the best morphology. So we see all different things. Sometimes we have surprises, don't we, when we have a very poor quality embryo and we have a beautiful, healthy live birth. So I think the future will see much more genome testing, genetic testing, morphogenetic testing, maybe metabolomic testing, and with a synchronous endometrium, a healthy endometrium, we should see continuous improvement in our outcomes.
Yes, I think the AI has been quite of developing. With the time lapse, you may see the microfluidics, which takes it to the metabolomics, and those things are integrated to have the report being generated, which clubbed with the embryo selection gives you the best options for selecting the embryo to thaw those which you have to be transferred later on. So it is a very interesting future which we are getting into with all the development of technology and the processes which we have. If they get clubbed, I think we will get a good outcome of it.
It's a lot of answers lying with the AI as well as the time-lapse systems.
Yeah.
So not to explore. Coming to the next question. Any extra precaution needed for fully hatched blast in freezing and thawing? But if hatched blast is collapsed post-biopsy? There are two questions there.
Well, they're very difficult to handle compared to a blastocyst inside the zona. They're a little bit sticky, they're amorphous, it's not easy. So I think one thing to say on this point is day 5 in the afternoon, maybe check, because if they are really expanded in the afternoon of day 5 after a snapshot observation in the morning, the chances are you might have a blastocyst that's hatched on day 6 to deal with. So it may be better to vitrify it on the afternoon of day 5 to avoid yourself getting into this scenario, because we don't handle that hatch blastocyst every day. So it's not a skill that everybody has, like a blastocyst in its zona. So it is more difficult. So I think the best way is with a large diameter, large 300 plus, don't know what you use here, but larger one, and very gentle pipetting, confident, and check it's moving within the pipette before you take it across to the next, and so you can just anticipate if it's going to stick. And have you got any personal top tips with
no, in fact, very true. Like as you said, that yes, the embryos, they should be screened in the evening as well. That is very important, because most of the time what we do is that we do the grading part in the first time in the morning, and then we rely on that grading for the whole of the day. And there we decide that okay, we'll take these embryos to day 6. And rather taking them to day 6, it's a good practice to at least peep into the embryos that how they're running into the evening.
Yeah, so first thing is please recheck it so that you avoid this particular circumstances. And secondly, obviously, if it goes to that level, even after checking at the evening and then the next day if it is hatched, as rightly said by Professor Alison, that be very wise, do a very gentle pipetting, use a 300 or larger micro pipette so that you can handle it appropriately. And I would recommend using single embryo freezing over here, because you have to carefully see that, and if you're clubbing it with another completely expanded blastocyst, possibly we don't know where the hatch blastocyst has gone, and you have to be very careful while freezing those hatch blastocysts by loading it and then plunging it. So maybe that is what I have faced, and I used to do it that if it is a hatch blastocyst, I didn't used to mix it with another expanded blastocyst because then handling becomes a challenge.
Yeah.
That is what I used to do.
Yeah, super challenging then.
Do you recommend giving a laser shot for the hatching blast, just with an intent that it will regress and it will go back to the
Not really, no.
That's really.
So with an intent that okay, it will go back to from where it has come from, the zona. So it's
Yeah.
Yeah, well, it's possible to push it back in, but yeah, fire a laser to send it on its way. I don't know. What if it's hatched? What if the blastocyst is hatched? It's collapsed post biopsy. Hatched blastocyst collapsed post biopsy. It's quite normal that it would collapse after a biopsy. And I think it's okay. Treat it as you would another blastocyst. Put it back into culture for a while, and if it doesn't re-expand, I wouldn't worry too much. It's probably slightly easier to handle. Get it onto the straw and vitrified, and hope that it recovers well afterwards.
Yes, because it doesn't have any shape, and then we have straight.
The only challenge is that we can't, grade them after grading them, but otherwise you have to just rely on the initial grading.
Thawing time or expansion time, which is more important for pregnancy?
Well, they're both important. So the thawing time in terms of, think you mean from the liquid nitrogen to the TS, very fast. Then we have a minute in the TS, and now we know it may not be necessary to go through the dilution solutions. We might be fine. I believe we're fine to go straight to culture. So that protocol is very important. And then expansion after warming is also important. And they're both going to make a difference to your pregnancy rates. So I'd say they're both important. It's really hard to say which one, if you had to choose. I think you'd probably say the thawing time, because that's your protocol, and if you mess up with your thawing time, if something goes wrong, then you probably won't get your re-expansion anyway.
Yeah, right. So post-thawing, if it is about expansion, and that is obviously the warming rate, which is first, which has to be attained, so that we can have a right survival. And post that expansion, maybe 3 to 4 hours. If it is day 5 freezing, it doesn't matter much. If it is day 6 freezing, then what would you recommend? Shall we wait for 3 to 4 hours? And even at that, if there is not much expansion, should we go ahead with transfer, or can we wait for more time? Especially if it is day 6 embryo with regards to expansion.
I think we can wait a little bit more, but the clock's ticking and everything's synchronized, and we believe that the embryo can wait for the endometrium, but the endometrium can't wait for the embryo. So we need to try and balance those concepts. And also we've got a patient waiting. We have to think about the patient. We may have more embryos in the cryo store, we may not. So we have to consider all of these factors. So we have to personalize, I think, in situations like that.
On to the next question. Anuj is asking, what should be the most ideal time to transfer embryos post-thawing? Is it 2 to 3 hours post-thawing, or we should wait for the blastocyst to fully expand, slightly hatch, and then transfer?
Well, it's best to be consistent, I think, because we're still learning and we're still optimizing, and 2 to 3 hours is typically what is recommended. And I think as long as we've seen some re-expansion, that's a really good sign. The embryo is doing what it needs to do. And we don't know, unless we've got photographs of the embryo before it was vitrified, exactly the diameter that it was. And we know that the diameter is variable, and the photograph may have been taken 1 hour before vitrification or 5 minutes before. So we need to try and gauge that. So it's hard for us to say, now this is fully back to what it was, because I don't think we can accurately remember or recall what it was before we vitrified it. So I don't think we should just keep waiting and waiting. We need to be quite confident that if we're seeing signs of recovery in terms of re-expansion after 2 to 3 hours, that's for me is good enough.
right? So it's a clear message that 2 to 3 hours waiting post thaw, that is sufficient, and we should not actually wait longer time for them to hatch or expand to the original size.
So it's like all correlations operationally, patient waiting, what time we have, day 5, day 6, and it's a decision which an embryologist has to take, being mindful with regards to circumstances in front of them for the transfers. I think the last question which we have in the chat is there an effect of philopodia, that is the cytoplasmic springs, in the blastocyst with regards to survival rates, I think post biopsy? Post biopsy survival rates. Survival rates from biopsied embryos having cytoplasmic springs.
Oh, right. Quite a subset.
Yeah.
I'm not aware of any data on this actually, but I don't see why the presence of cytoplasmic springs in a blastocyst that had been biopsied would affect its post-warm survival. So we probably need some more studies on this to be sure, but they're a common phenomenon and we shouldn't worry too much. I think what we do know in terms, it's not really cytoplasmic string related, but the collapse and re-expansion episodes is not really a good sign. If we see multiple collapse and re-expansion episodes, that's hard to see without the benefit of time lapse. But sometimes we can use these lessons that we have from dynamic assessment of embryos and apply them to our static observations. So if, for example, you were to make a couple of observations of the blastocyst and you saw that it collapsed and re-expanded the next time, yeah, you might be able to make some sort of glean something from that, but not unless you see multiple episodes. So yeah, it's a difficult one. We do need to study this a little bit more. I'm not aware of any impact on survival.
Yeah, I mean, I am not aware. I mean, to a certain extent, I used to always link philopodia with good blastocysts because I have seen more in good blastocysts than in grade B, C blastocysts. And I used to be very careful if I see philopodia because it shows inner cell migration, which possibly means are there any two inner cell mass also? If there are springs attaching it, then check for two cell masses because there might be some migration going on. So be extra careful. But it's a sign of good embryos. I don't think so there will be any effect of that on the survival rates post biopsy.
I think there are a couple of questions in the question answer section as well. Are cleavage stage embryos more susceptible to cryo damage than blastocysts? Why and why not?
Well, the cytoplasmic and the membrane ratio is very different. I mean, we don't have a lot of experience with early cleavage embryo vitrification. So I think it's hard to compare the cryo survival rates between blastocysts and early cleavage stage because most of the data we have from cleavage stage embryo cryopreservation was slow, computer controlled slow freezing, which was less effective than vitrification. So we did see poorer survival rates. So it's hard to say. I don't know. Would you vitrify cleavage stage embryos?
Not these days.
No.
Not these days, actually.
No. Best practice is to culture onto blastocyst and vitrify the blastocyst stage. There's much more data and evidence to support that. Certainly no slow freezing anymore. So yeah, I think we don't really need to observe the cleavage stage anymore. And the Istanbul consensus does give some guidance on assessing cleavage stage embryos because some clinics do still do that routinely.
Yes, true.
But the general recommendation is not to do that, and it's to culture to blastocysts and really perfect your blastocyst culture and assessment practice.
Yes, I'm aware. When I also know some of the clinics which do 2 to 3 embryos freezing on the cleavage stage, the best ones, so that they assure the embryo transfer for patient and take rest to the blastocyst, and then of whatever blastocyst form they freeze it as a plan B, and then you at the end get confused if you have a good quality grade 1 cleavage stage embryos and a good quality grade 1 blastocyst will be for the first one to transfer and second one to transfer. So, and then you take out 5 of them and take into blastocyst and see which is the best surviving, and then so it's like end up into the mess, and it's very
complicated. It's actually
yes.
complicated.
Yeah.
And what in actual should be the plan A is becoming the plan B.
Yeah. True. I think the last one which we have is how do the blastocyst expansion and inner cell mass quality influence the cryo survival.
Well, I think we've covered this somewhat. So
yes,
yeah, the morphology of the inner cell mass and the morphology of the trophectoderm can both influence cryo survival. The expansion stage does not appear to influence cryo survival at all. So we can get great survival at expansion stage or blastocyst stage 1, 2, 3, right through. So yeah, that is not really it's not really of relevance in terms of cryo survival, but we need to look beyond cryo survival because 99% of blastocysts, irrespective of their expansion stage, will survive vitrification and warming. But we need more than survival. We need implantation and we need healthy live birth. So that's where the morphology comes in, and so that's why better expansion and good morphology will give us the best clinical outcomes. So that's where we need to think is the outcome measures that are the most important, are those clinical outcomes, and not so cryo survival is important, but we need to look beyond that. We don't just want survival, we want a baby. And so, yeah, that's probably the
right. It's such a good improvement in the media over the last decades or two. The freezing point has comparatively become easier than what it used to be in the past with the support of these media. And that's why generally nowadays it's very confidently we can say what goes in comes out. You just have to do the best job.
Yep.
And then it is what we always live for is the live birth. That is what the aim is, and not just the transfer.
With this, we come to the end of the session, and I really thank from the core of my heart to Professor Alison for taking out time. I know it was your holiday, but still you were courteous enough to give us your precious time and being so patient while answering all the questions. And
yes, we kidnapped her out of her vacation for our session. Thank you very much for being that graceful to devote that time and it's like give such a valuable inputs and such a beautiful presentation to the audience, which will help them practically in their day-to-day life to improvise their grading and consideration.
Thank you very much. Thank you very much.
Okay, then see you guys on the 3rd Friday of March with another interesting topic and some insightful views and thoughts on that topic. Thank you. Thank you.
Thank you.
Being a patient listener.
Yes. Have a wonderful evening and see you next time with another speaker and another beautiful topic. Have a nice evening.